Oslo to discuss the MITOCARE study, the effect of intravenous TRO 40303 as an adjunct to primary PCI for acute STEMI.
Chairman, ladies and gentlemen, declaration of interests are displayed here. The MITOCARE study had the following rationale. TRO 40303 has been shown to reduce infarct size by 50% in rat and mouse models and to improve LVEF at 1 day and 1 month in these models. It has also shown protective effects on isolated human cells. The mechanism is thought to be linked to the mitochondrial permeability transition pore, which is a promising target for preventing reperfusion injury. TRO 40303 has shown to inhibit the opening of this transition pore. This trial enrolled patients since October 2011 for almost 2 years and included 10 interventional sites in Denmark, France, Norway, and Sweden. This slide shows the study design. Patients were immediately upon hospitalization randomized to either drug or placebo given IV as a bolus by a large peripheral vein just before balloon inflation. Inclusion criteria included a first-time STEMI presenting within 6 hours of chest pain, clinical decision to treat with primary PCI, and they had to have a completely occluded culprit lesion, which means TIMI-flow 0-1. The x-axis shows the timeline of the study with troponin I and CK measurements taken at these time points. At day 3, 4, and 5, there was a cardiac MRI investigation and an echocardiography, and the follow-up consisted of safety analysis after 1 month and an echocardiographic investigation. Just a key procedural characteristics line shown here. The pain to balloon time was approximately 3 hours in these patients, and the consortium takes pride to a door to balloon time in all patients, all sites, in average of 38 minutes. Let us turn to the results. CK levels over time are displayed on the upper panel, troponin I on the lower panel. As you see, the curves are not showing any significant differences. Area under the curves are computed and displayed as bar graphs on the right-hand side panels, showing no significant differences. How about MRI endpoints? The major MRI endpoint, myocardial salvage index, was 0.58 in placebo versus 0.52 in the experimental group, showing no significant difference. Other important parameters included infarct size, expressed as percentage of the left ventricle, 0.15 versus 0.17, infarct size in grams, 20 versus 22 grams, and LV ejection fraction, 48% versus 46%. As you see, obviously, no difference of significance. An additional echo investigation after 1 month revealed these data: LVEF approximately 52% in both study arms, and the volume parameters shown on the upper panel, either of those any significant differences. We can conclude that the MITOCARE trial did not show any protective effect of TRO 40303 as compared to placebo in preventing reperfusion injury in STEMI patients treated with primary PCI. A high standard of care accounted for the relatively small infarct size after primary PCI, and actually this is leaving little room for improvement. These results, combined with the many failures in the field, raise a provocative issue: whether reperfusion injury indeed occurs in man, and if it does, whether this type of injury really accounts for a significant part of the remaining infarct. Thank you for your attention.
Questions for Dr. Atar, please. Dan, in just the briefest terms, could you explain the mechanism by which this agent was supposed to help?
Yes, we do have data from other groups showing that cyclosporine was effectively reducing infarct size in STEMI patients. Cyclosporine has a very clear effect on the mitochondrial opening pore, inhibiting it, and this more targeted approach that we tested in this trial would deliver the same mechanistic effect.
Okay, thank you, Don. I think we move on. You'll be here.